Hello, everyone, and welcome to this special webinar, Navigating COVID-19, Telehealth Loans and Regulatory Updates. I'm your host, Charlotte Bonet, WebPT Senior Director of Demand Gen. Now, before I hand things over to our hosts, I'm going to cover a few housekeeping items. This webinar will last 90 minutes with roughly 60 minutes of presentation. We have a lot of updates, and about 30 minutes of Q&A. If you have a question during the webinar, go ahead and ask it in the side panel. We'll do our best to answer as many questions as possible by the end of the presentation. We're recording this webinar and will automatically send the entire recording, slide deck, and a copy of our FAQ blog post that covers all the questions that people have been asking in this series of webinars to everyone, hopefully by the end of the day. If you've joined us for a previous webinar during the COVID-19 pandemic, then you've probably already heard me say this, but it bears repeating. Policies, guidelines, and best practices on these topics are changing fast. So while we have done and will continue to do our absolute best to bring you the most accurate, up-to-date information possible, understand that we are not the end-all, be-all authority, and the information presented here may very well change. That's why we always recommend verifying all billing and regulatory information with the appropriate source, whether that's a payer, your state, government or board, or CMS. And with that out of the way, I'll hand it over to Heidi.
Hello, everyone. I am Heidi Janenga, physical therapist, co-founder, and chief clinical officer of WebPT, which is a web-based software platform for physical therapists, occupational therapists, and speech-language pathologists. My co-founder and I started this company back in 2008 because there wasn't a documentation solution available at the time that truly suited my needs as a physical therapist and clinic director. Since then, we've grown to more than 80,000 members across 15,000 practices all over the United States. We here at WebPT host these free webinars because one of our goals as a company is to help rehab therapists achieve greatness in practice. And I truly believe that that starts with education. So with that, today I am honored to be joined by John Wallace, WebPT's Chief Business Development Officer of Revenue Cycle Management, and Vita Colmer, WebPT's Chief Compliance Officer. Thank you so much for being here today, and welcome.
Thanks, Heidi. I'm glad to be here.
Yes, thank you, Heidi. Happy to be here.
All right, everyone, so let's get to it. As Charlotte mentioned, the COVID-19 response is moving at a furious pace, with changes happening by the day, sometimes even by the hour. Staying on top of all rehab-related news can feel impossible. Not to worry, though, because we're staying on top of it. And today I have our billing and legal experts here with me to guide you through the next phase of this ever-evolving situation. During the last webinar, the three of us hosted back in late March. Wow, that feels like a lifetime ago. We spent most of the time detailing business continuity strategies, as well as strategies for keeping your staff and patients safe and healthy. So we're going to keep that part of the discussion today fairly high level. That way we have plenty of room to delve into financial assistance, billing, and telehealth, as well as answer your questions as they come in. Now, if you want to learn more about any of these topics, please go to our webinar page on our blog to watch our first broadcast on this subject, or you can go to our downloads page to get our free copy of the Business Continuity Guide. So with that, let's jump right into that high-level business continuity discussion. I'm going to share some key things practices should be doing right now as we speak. First up, let's talk about altering your approach to treatment. Now, although many clinics are remaining open as essential businesses, WebPT data shows that visits are down across the United States by as much as 50%. So in order to provide continuity of care, minimize the risk of transmission, and try to maintain some cash flow, you should be leveraging remote and virtual treatment as well as home visits. Now, as it stands, CMS and some commercial payers will reimburse PT, OT, and SLPs for home health visits and certain virtual care services provided during the COVID-19 response. We'll discuss the specifics of virtual care services later on in the presentation. But for now, know that while Medicare does not currently cover PT, OT, or SLP provided telehealth services, it does cover e-visits, virtual check-ins, and remote evaluations of images and video, as well as telephone visits, which we'll define shortly. If you are a WebPT member, you're already able to use the REACH platform to satisfy the e-visits criteria, as well as apply virtual check-in codes, e-visit codes, telephone codes, and place of service codes within the WebPT EMR. Now, let's talk about business contracts. I would recommend starting with your commercial lease. After all, most landlords would rather negotiate with a great tenant and keep some money coming in month over month than lose that tenant forever, especially now. So when trying to replace you is really, really hard to do. Now, that said, direct, honest, respectful communication early and often will be very important, as your landlord is most likely struggling during this time as well. Here are some options that you may propose to that landlord. An option of rent deferral, which is a postponement of rental payments or a portion of those payments for an agreed upon period of time. You could also suggest rent abatement, which is a suspension of rent payments or a portion of those payments for an agreed upon period of time. There's also just the negotiation of complete rent reduction, which is the reduction of your rent payments or a portion of those payments for an agreed upon period of time. And the last is an opportunity for a loan conversion, which is a conversion of past due rent payments into a loan that is payable over time. However, you would continue to pay your current rent.
And beyond your landlord, you may also want to reach out to your company's employee benefit providers to inquire about payment reduction or deferrals for up to 90 days. If your practice has fewer than 500 employees, you may also be eligible for the CARES Act financing options, which we'll discuss in greater detail in a little bit. For guidance here, reach out to your accountant or an employee attorney to help you determine what's right for your company. However, you must act fast because there is a finite amount of money available to be distributed on a first-come, first-served basis. And that money may be very limited right now, possibly gone, but we'll talk about that further in detail later.
All right, moving on. This crisis also highlights the importance of collecting co-payments and co-insurance at the time of service. After all, patients who may have had funds available to pay their outstanding balances in February may not actually have that free-flowing cash right now. But with the number of claims reduced, it's now more important than ever to collect as much outstanding AR as possible. So that means the possibility of tasking some of your therapists to finalize outstanding documentation on past patient visits and get claims sent out ASAP, tasking out your front office staff with reviewing and correcting all denied claims so your AR is squeaky clean post this pandemic. And then delicately, and I'll emphasize delicately because you want to pursue patient outstanding balances from recent visits. And I would maybe caveat those to the ones that are past due over the last 30 days. But just to note that this really requires a very gentle touch right now, as you don't want to place added stress on patients and then potentially lose them forever.
And you may also want to consider leveraging the Medicare Accelerated and Advanced Payment Program. Now, I'll talk about this in a bit more detail shortly, but it's definitely worth exploring when examining your AR.
Okay, next up, let's talk about staffing. PTs, OTs, and speech therapists have officially been deemed essential workers, so you may decide to keep your clinic open. However, as mentioned before, based on the data from WebPT, we know our members have experienced at least a 50% drop in patient volumes, and that's all the way across the United States. So if that's the case for your organization, you may not be able to keep everyone on staff during this crisis. So here are some other options to consider. And just as an aside, make sure you're consulting with your practice's legal counsel first before implementing any of these specifics. Now, the first option may be to repurpose existing job roles. For example, if patient volume is low, consider having your clinical staff handle project-based work that will help streamline operations on the other side of this pandemic, or support your front office staff with collecting outstanding AR or completing audit reviews. Temporarily reduce pay or work hours. This can actually help overall pay costs in the short term. If you're leaning towards reducing pay, you can also apply these cuts as an across-the-board percentage reduction, starting with your higher salaried leadership teams. Next, you might want to require staff to use their paid time off, or PTO, as well as vacation time. This allows employees to have some access to income during this time period, even without having to actually work hours. And lastly, you may want to encourage voluntary unpaid time off. Now, while it might seem a little tough to convince employees to take voluntary unpaid time to preserve business viability, there may be some employees who may be willing to do this so that other employees may still get paid.
2 more strategies to consider. Enacting furloughs. During a furlough, employees are asked or required to take short-term unpaid leave in order to reduce payroll costs. However, they still retain their employed status in order to maintain benefits eligibility. This means that you're not paying employees their wages, but you're still ensuring that they have health care. Now, some employees may be able to continue covering their share of their employees' health insurance premiums during the furlough period, while others may have to pass this cost on to their employees, similar to COBRA, and still others will have to opt to disperse these costs to be paid by the employee at a later date. Regardless of how you set it up, though, furloughs protect insurance coverage. And then another option to consider is to conduct layoffs, and this involves employment termination with the possibility of rehire at some point in the future.
Okay, so let's focus on operations. So there's no way to actually know how long the shelter-in-place rules will remain, but we do know that they will not last forever. So use this time that you have to shore up your business practices so that when the time comes to actually reopen your doors and start treating patients again, you'll be ready. That might look different to each one of you out there, but some ideas might be to explore opportunities for automation to streamline your operations, cultivate new referral relationships, and definitely maintain the current ones you have. Start developing a strategy around future efforts to reach prospective patients, reviewing all policies and procedures and shoring up any that need some attention, streamlining your practice's billing and AR workflows and identifying opportunities for improvement, and finally, reviewing your data and cleaning it up so that it's presentable and actionable. And on this point, I would encourage you to use this time to shore up your metrics collection. Data can help you get a better understanding of how your practice is currently faring and what you may be able to expect going forward. Plus, having this type of data available to you after the COVID threat has passed can help you establish a business continuity plan that accounts for something like this going forward. Now, one key data point to track is your appointment cancellation rates. Be sure to denote the reason for these cancellations as COVID-19. That way, you'll be able to assess the true impact of this crisis on your clinic and use that information to create plans for the future, like how much cash you should have in reserve to float your practice through such a significant loss in revenue.
And I'd also encourage you to complete your annual HIPAA training and perform your HIPAA risk assessment in your practice. And typically in your day-to-day, completing the HIPAA risk assessment, especially for the first time, can be challenging when you're juggling other priorities. So this would be a great time to tackle that beefy task The OCR has a free resource for conducting HIPAA risk assessments available on the Health and Human Services website at healthit.gov. If you search OCR Security Risk Assessment Tool in your search engine, it should be the first result. WebPT's also created quite a bit of content in the past about tackling your HIPAA risk assessment in your practice. Simply search WebPT blog HIPAA risk assessment to find those articles on our website. And lastly, if you are participating in MIPS, use this time to plan your improvement activities.
Now, I know there are a lot of tips on this slide, and they're pretty high level, and so that's why I'm actually in the process of creating a series of articles to help providers focus their efforts on their business when they can't work in their business. The first post in that series was published last week. We have another one coming by the end of this week. So find it on the WebPT blog and stay tuned for more hitting our website over the coming weeks. Okay, so if you've attended a prior webinar, you have probably heard me talk about this before, but I honestly can't say it enough to hopefully inspire some action. In this time of healthcare crisis and frankly business crisis, we must stand up for ourselves and our livelihood. There are numerous opportunities for rehab therapists to advocate for expanded telehealth access right now, access that has the very real possibility of extending beyond this COVID-19 response. After all, if we can establish ourselves as authorized providers of any and all telehealth services now, and we can demonstrate how telehealth empowers us to provide greater continuity of care to our most vulnerable patients, then we'll have a much better chance of maintaining our status on the other side of this as opposed to starting from scratch. There are several opportunities for you to participate in these advocacy efforts right now. First, the private practice section, or PPS, of the APTA is organizing an effort to encourage lawmakers to pass telehealth legislation that will allow PTs to meet our patients' current and immediate needs and mitigate some of the revenue losses that we face. I know we have a lot on our minds right now, but if you're a PT, I urge you to support PPS's advocacy effort, even if you're not an APTA member. Now, second, the Creating Opportunities Now for Necessary and Effective Care Technologies, better known as the Connect for Healthcare Act, which is House Bill 4932 or Senate Bill 2741, is bipartisan legislation that would expand the use of telehealth services and ease restrictions on telehealth coverage under the Medicare program for all rehab therapists. So please contact your legislators in the House and the Senate to ask them for support of this bill and waive the telehealth restrictions that apply to us as rehab therapists under Medicare. The APTA has made this extremely simple. All you need to do is know your zip code, and their template does the rest for you. It just takes literally 2 minutes to complete. Third, WebPT has created template letters that PTs, OTs, and SLPs, respectively, can send to CMS Administrator Seema Verma requesting that rehab therapists receive authorization to provide telehealth services ASAP. Simply download your free template, copy and paste it into an email, add your individual information, and hit send. Super simple, so no excuse not to do it. Get your template at webpt.com/telehealthadvocacy. Successfully getting rehab therapists classified as full-fledged telehealth providers could not only mean the difference between clinics staying open or indefinitely shutting their doors, but also ensure that we can continue to support our patients remotely beyond COVID-19. And finally, we can't lose sight of that 8% cut that is scheduled to hit our Medicare payments in 2021. So we must continue to sound the alarm, especially in this volatile environment, because our industry cannot sustain that type of revenue hit as we recover from this pandemic. So this is our professional responsibility, and frankly, there is no excuse if we have the time now, especially now, to take action. All right. I'm stepping down off my soapbox, I promise, to discuss the last business continuity strategy, as it perfectly segues into the middle of our presentation, which is financial assistance. There's a lot of financial assistance resources available to businesses as well as individuals. We're going to talk through some of the main ones during this webinar, but also encourage you all to do your due diligence in researching the state and federal funding opportunities available to you and your practice specifically.
First, let's talk about the Medicare Accelerated and Advanced Payment Program, as this is something we've received a lot of questions on from our members here at WebPT. As a means to assist practices under contract with Medicare, CMS announced a program that will enable Part A and Part B providers to receive an advance payment equal to or less than what the practice collected from CMS during the previous 3-month period. Once approved, practices will receive a lump sum directly from CMS. Then, 120 days later, CMS will automatically start putting all payments due to the practice towards that outstanding balance until it has been zeroed out. No additional interest or fees will be charged for this advance payment. To be eligible, practices must have billed Medicare for claims within 180 days immediately prior to the date of signature on the provider's or supplier's request form, not be in bankruptcy, not be under active medical review or program integrity investigation, and not have an outstanding delinquent Medicare overpayments. Now, how much should you ask for? While most practices will be able to request up to 100% of the Medicare payment amount for a 3-month period, you will need to determine the right amount for your practice because you can borrow less than that amount. Just remember that after the 120 days, you will not have any revenue from Medicare until the amount you borrowed is paid in full. As a result, you'll need to plan for that time period, especially if Medicare is one of your primary payers. To apply, you'll need to contact your Medicare Administrative Contractor or your MAC. MACs have been updating their websites with a fairly simple application process. Once approved, providers will receive the advance payments within 7 calendar days.
And also on the Medicare side of things, CMS has paused its 2% sequestration reduction from May 1st to December 31st, which will allow for slightly higher Medicare reimbursements, which is nice.
So let's talk about the recently enacted CARES Act. It has several provisions for businesses that improve liquidity through tax deductions, credits, deferments, and loans. These include delayed payroll tax deposits. The deadline for employers to make Social Security tax payments on 2020 payroll has been extended until 2021 and 2022. Those who are self-employed can also defer a portion of their Social Security tax. However, borrowers who receive forgiveness on a Paycheck Protection Program loan, which we'll discuss in a bit, are not eligible for the payroll tax delay. Another option is net operating loss carrybacks. Now, net operating losses, or NOLs, can help you reduce taxable income by allowing your business to record losses in order to offset future taxable income. In general, NOLs can only be applied to future years, and they're capped at 80% of the business's taxable income. However, the CARES Act temporarily allows application of NOLs for the past 5 years, and it also suspends that 80% limitation. So what does this mean for your therapy practice? If you were attempting to recover from a few low profit years without the CARES Act release, this year's income loss could pose a formidable barrier for financial recovery. However, the CARES Act provisions allow you valuable tax relief to help you right-size your practice. So if you experience a profit loss this year, NOLs will offer you valuable tax support in 2021 to move your practice's budget back into the black. A third option is the employee retention tax credits. employers who have not received that payment protection loan, the Paycheck Protection Program loan, PPP loan, are eligible to receive a payroll tax credit for 50% of wages paid, plus the allocable portion of the cost of group health plan coverage from March 13th to December 21st, 2020, if their operations were at all suspended due to COVID-19, or their gross receipts declined by more than 50% when compared to the same quarter in the previous year. So let's tackle the two Small Business Association disaster loans. The first loan is the Economic Injury Disaster Loans, the EIDL loans. These are low interest loans, meaning up to 3.75% interest for a 30-year term. And they're emergency loan options for businesses that suffer substantial economic injury. EIDLs also come with the ability to defer principal and interest payments for 4 years. These loans provide businesses for up to $2 million with advancements of $10,000 available within 3 days of submitting the application. While the advancements do not need to be paid back, there is no forgiveness option on the bulk of the loan. No personal guarantees are required for the loans up to $200,000, and the loans can be made based solely on the applicant's credit score.
Now, funds can also be used to cover payroll and other operating expenses that would have been met if not for the current crisis. Applications are available on the SBA website, and borrowers who receive an EIDL loan between January 21st, 2020 and June 30th, 2020 may later refinance that loan into a PPP loan, which we're going to talk about next.
All right, so the PPP loan. Before I get started on this information, I will say up front that in the news today, we learned that the PPP loans right now are out of money, and the Small Business Association is not accepting more applications at this time. However, there is legislation in the works to hopefully authorize more money for these loans soon. So stay tuned, and then don't tune out on this information because it will be relevant if there is more money added to the PPP loans. So these loans are designed to help small U.S.-based businesses, particularly those with fewer than 500 full and part-time employees, and this is not counting independent contractors, to cover their payroll expenses and operating costs through June 30th, 2020, by providing loans up to $10 million. On the SBA website, you'll find a location feature that can help you find a PPP lender in your area, and the PPP funds can be used for per employee compensation up to $100,000 annually, and that's about $8,333 per month, including salary, wages, vacation pay, family, sick, medical leave, healthcare, retirement, and state and local taxes. And then it can also be used to pay mortgage interest, rent, utilities, and other interests on debt obligations that were incurred before February 15th, 2020. To be eligible for a PPP loan, rehab therapy practices must have been operating on February 15th, 2020, and be willing to certify that the loan is necessary to support ongoing operations or as a result of the current crisis. The loan will be used to retain workers and maintain payroll and/or mortgage payments, lease payments, or utility payments, and the company has not received any other SBA loan for the same purpose.
Now, please note that things get a little more complicated if you are venture capital affiliated or private equity backed, as the investor and its portfolio companies may result in an aggregation of employees that exceeds the PPP threshold. Now, to determine eligibility, we recommend reaching out to a legal or tax advisor. Now, also note that the SBA will waive some of the traditional loan requirements to remove barriers to lending. Specifically, there is no requirement to improve inability to obtain credit elsewhere, and owners with 20% or more ownership do not have to contribute liquid assets to obtain the loan. And I'll just quickly underscore the breaking news that VITA stated about the SBA's $349 billion Paycheck Protection Program officially running out of money as of yesterday. And Senate is currently in a stalemate over an additional $250 billion PPP injection. So just another point for advocacy on behalf of small businesses out there. Contact your legislators to help them really get this injection passed.
All right, so we're going to keep our fingers crossed that those loans start flowing again soon. But more good news about the PPP loans is that they are federal government guaranteed. They are fee-free, and we know that they're on a first come, first served basis, which we've already talked about. But also, payments of principal and interest are deferrable for at least 6 months, and loan balances will remain fully guaranteed with interest rates capped at 4% and a loan maturity rate of 2 years. So the loan amounts cannot exceed 250% of a business's average monthly payroll cost from the prior year. For reference, you will need your payroll taxes, payroll processor records, and or your 1099 MISC or income and expense for sole proprietors. To calculate the loan amount, first aggregate payroll costs from the last 12 months for all U.S. resident employees. Then subtract employee compensation exceeding $100,000 a year annually and the amounts that you've paid to independent contractors. Then the third step is to calculate average monthly payroll costs by dividing that payroll by 12. And then multiply that average monthly payroll by 2.5. And then you'll add outstanding amounts from the EIDL loans between January 31st and April 30th. So that will give you the amount that you can ask for in the loan. As for the loan forgivenesses, borrowers can apply for forgiveness on all or a portion of the PPP loan for up to 8 weeks after the loan is issued by providing documentation demonstrating that the loan funds were used appropriately. However, only 25% of non-payroll costs can be forgiven. Forgiveness only applies to amounts paid during the covered period, that is February 15th through June 30th. Amounts paid on other debt obligations will not be forgiven. If the company still has to lay off employees or reduce hours during the covered period, which is that February 15th through June 30th, the amount of the reduction or salary for the laid off employees will be deducted from the amount to be forgiven. And the unforgiven remainder of the loan will then be treated as a loan with a 2-year maturity period.
Okay, so now let's talk about some of the financial relief provisions available to individuals who have been personally affected by this crisis. Individuals will receive funds directly from the federal government based on the income reported on their 2018 or 2019 tax returns. Individuals earning less than $75,000 adjusted gross income per year can expect a one-time cash payment of $1,200 paid via direct deposit if on file. Otherwise, a paper check will be mailed. Married couples who file jointly and earn less than $150,000 will receive $2,400. Families will receive an additional $500 per dependent child under the age of 17. Stimulus checks will be reduced by $5 for every additional $100 of adjusted gross income. Individuals who make more than $99,000 and married couples who make more than $198,000 will not receive any of these funds.
As for the impact of all this on retirement plans, under the latest guidelines, retirement plan loan limits are temporarily increased and loan repayments are delayed. For the next 5 months or so, individuals with access to their retirement accounts are now authorized to withdraw up to $100,000, so 100% of their vested 401k balance from the defined contribution retirement plans in the form of a loan. While loans are usually limited to 50% of the vested account balance with a maximum loan amount of $50,000, both limits have been raised. Additionally, these loans are not subject to early distribution penalty, and taxation can be spread over a 3-year period. Any existing 401k loan repayments that would otherwise be due between March 27 and December 31 can be delayed. Also, the required minimum distribution, the RMD, from a defined contribution plan, such as a 401k or an IRA, have been waived for 2020, which provides relief for those individuals who do not need to access the retirement plan now, but have seen their funds depleted due to the COVID-19 related stock market downturn. So this allows for retirement accounts to recover.
Now, with respect to student loans, which we have shown that is a major problem in our industry, employers now may provide employees with up to $5,250 in tax-free payment toward their student loan obligations. Additionally, all federal student loan payments are suspended through at least September 30th without interest accrual.
So I'm sure many of you have read how high unemployment is. I think it's at 16 million right now. The good news is that under the CARES Act, individuals who lose their employment or have their hours reduced no longer have to wait that 1-week waiting period to obtain unemployment benefits. Additionally, unemployment benefits have been increased to $600 per week above the state-established unemployment amount for a period of 4 months. Now, this increase is under the Pandemic Unemployment Assistance Program as part of the CARES Act, and it's available for employees who are typically not eligible for state employment, such as independent contractors and self-employed individuals. And it covers a broad range of unemployment circumstances. To learn more about eligibility requirements and benefits, go to the Department of Labor website or contact your state's unemployment insurance office. You can find contact information for your state unemployment insurance office on the Department of Labor's website.
All right. Thank you, Vita. Okay, we're going to switch gears to the final portion of our webinar, telehealth and billing. We're going to delve into exactly how you can provide and bill for remote therapy services, but first, we're going to quickly run through the definition of these services themselves. It's important to understand the differences between all of these visit types.
That is exactly right, Shar. And as it stands, there are 5 main types of virtual services available to patients, each with its own parameters and guidelines. First, a telehealth visit. During this visit, the patient and provider connect over a telecommunication platform for treatment that would otherwise occur in person. As it stands, PTs, OTs, and SLPs are not authorized to provide true telehealth services to Medicare beneficiaries unless they are billing incident to a physician. However, if a Medicare patient would like to receive telehealth rehab services, then you may charge that patient out of pocket. If you go this route, we strongly recommend issuing a voluntary advance beneficiary notice for non-coverage or an ABN. Now, I'll just put as an aside, there has been some controversy around the billing of incident to a physician. It's on a recent call with Medicare, there was a question mark put around this, whether are not PTs, OTs, and SLPs could actually bill incident to, as well as obviously not being able to bill at all for telehealth. So again, all of these things are changing rapidly. So please make sure that you are contacting your MAC to understand what is available in your specific area, and continue to watch the CMS website. And we'll continue to provide the most up-to-date information that we have. Now, when providing cash pay telehealth services, use your best clinical judgment to determine which services and associated tests and measures you can safely and realistically perform in a telehealth treatment environment. For commercial payers, you'll need to review your contract to determine whether or not you can charge patients out of pocket for these services. For commercial payers that reimburse for telehealth, you'll need to reach out to them directly, as some require specific CPT codes for reimbursement. All telehealth services should be conducted using a real-time, two-way video platform that meets all payer and HIPAA security criteria.
Okay, so next is telephone visits. During a telephone visit, an established patient and provider may connect via a real-time telephone call to discuss the patient's care. Telephone visits are designed mainly for synchronous assessment and management services that are supplemental to in-person visits. They do not account for technology use beyond the telephone. You should bill both Medicare and commercial payers for telephone services using CPT codes 98966 through 98968. Okay, e-visits. You've probably heard a lot about e-visits, as they were one of the first types made available to rehab therapists in light of COVID-19. During an e-visit, an established patient and provider may connect virtually via an approved online patient portal, such as WebPT's HEP. E-visits are designed mainly for asynchronous, that is non-real-time, assessment and management services that are supplemental to in-person visits. The codes for e-visits, G2061, G2062, and G2063, are specific to Medicare, although other payers may follow Medicare's billing guidelines.
Next is the online digital evaluation and management, or E&M services. These are essentially the commercial payer equivalent of an e-visit. Some, though not all, payers may cover these services, which you will be using billing codes 98970 through 98972. And finally, the virtual check-ins, remote evaluations of images and recorded video. Now, during this type of visit, an established patient and provider may connect briefly to discuss the patient's care. These visits may include both asynchronous information exchange, like sending images and videos via secure messaging or email, as well as synchronous phone calls to briefly discuss that information. Now, these visits are designed for assessment and management services that are supplemental to an in-person visit. These codes, CPT codes for these visits, include G2010 and G2012 and are specific to Medicare, although some commercial payers, again, may follow Medicare's billing guidelines. Now that we've reviewed the different virtual visit types, let's turn it over to our in-house billing expert, John Wallace, to provide some detailed updates and clarification of these visit types.
Thanks, Heidi. There has certainly been a lot of change, and we are definitely giving the short version on material that we have presented before. So if you're completely lost on telehealth, you might want to visit one of the two previous webinars we've done on this topic and fill in the blank spots for yourself. But as always, we want to caution you that all of this information is current, and it's based on the best information that we can get at the moment, which is as of this week. But just like the information we've presented in past webinars, this can be subject to change. Let's start with talking about CMS. So, as of April 15th, rehab therapists are still not authorized providers for telehealth for Medicare. Now, the CARES Act, which was passed on March 27th, gave CMS broad authority to waive parts of the Social Security Act relative to telehealth and much other type of service that is done. We're hopeful that because of this broad ability to change this, that they are working on another interim rule, and that we believe that the interim rule they want to incorporate all the changes in one fell swoop. So we're hoping that'll be out in the next week or two, and that we will be able to do some telehealth services with Medicare at that point. I know there's been a lot of frustration with the Part A providers about billing on the UBO4, which is the institutional format. And the big problem with Medicare right now is getting the MACs to agree on a revenue code for telehealth so those claims can be processed. So at this point, if you're trying to bill them on a UBO4, they're probably being denied, but they can be rebilled once that is fixed. So let's talk about the e-visits, which are G2061 through G2063. Now, what has been clarified over the last couple of weeks is these e-visits definitely need to be done via a patient portal. It has to be more than a telephone, and they can only be reported when the billing practice has an established relationship with the patient. So that's not new. But Medicare is allowing kind of the broadest perspective on what is an established patient. So an established patient can be someone you were treating for a problem before shelter-in-place went into effect, or it could be a patient that was familiar to your practice for another problem and now has a new problem. These have to be patient-initiated, so you can certainly inform patients you have e-visit capability, but they need to ask for them. And these are short-term assessments that happen within 7 days, and you accumulate the time within that period in order to decide which code to bill. And the critical element for documenting for e-visits are the patient's request or their concern or their question or what they're having problems with, your approach to understanding that better during the visit needs to be documented. Any clinical reasoning that you're using to decide on a course of action, and then to be clear on your plan going forward for the patient. So the place of service codes for the e-visits are unchanged, but the terminology around it changed a little bit. So Medicare wants you to use the place of service code that you would have typically used to provide service to the patient. So for most of us, that would be in the office, so place of service 11. But if you typically work from home as a therapist, then you would use place of service 12. Now, the CMS documents still say the CR modifier should be included, but we're seeing a number of MACs who are not paying with the CR modifier. So if you get an inappropriate modifier remark code on a denial, I would try removing the CR modifier. Additionally, as far as the GPGO and GN modifiers are concerned, Medicare had said that they wanted these included because these were sometimes therapy codes, although we're aware that half the MACs don't want these codes on them at the moment. But things are changing every week. So we are just, it's only been about 8 working days that we've seen claims coming back for these e-visits. So you need to take the time to read your remittance advice and find out what the denial or rejection reason was, and then correct that and rebill it. There's lots of resources available to sort that out if you need help with it. And finally, these e-visits do fall outside the parameters of the plan of care requirements for Medicare. So let's talk about the new virtual check-ins, and by new I mean this has really come to light in the last couple of weeks. So CMS developed 2 new codes that are, because they're short time, 5 to 10 minutes, and don't require special equipment, they're not paid very highly. So about $14. So although they're technology-based, they're not considered telehealth services, so they don't have to meet the telehealth technology requirements. CMS allows audio-only real-time telephone interactions, meaning that that if you're going to be looking at images, that those images are delivered to you separate from that session, and you can't record them at that session. The patient must send them to you outside of that, and I'll talk about that more when I talk about that specific code. So, but they do allow, in addition to synchronous two-way audio interactions that are enhanced with video or other kinds of data transmission. So let's talk about the G2012 code. So this is a brief communication technology-based service by a physician or other qualified healthcare professional who can report evaluation and management services provided to an established patient not originating from a related E&M service provided within the previous 7 days, nor leading to an E&M service or procedure within the next 24 hours of the soonest available appointment for 5 to 10 minutes. So in plain English, what they're saying there is that you can't have a billable service that occurred 7 days before this, and if it occurs within 24 hours after it, then the time you spent doing this would become part of that next encounter. So the virtual check-in is a very limited approach to interacting with your patient on generally a simple question, and it's usually going to be related to some other service you've previously done with them. Now, the G2010 code is a remote evaluation of recorded and or images submitted by an established patient. This would be some kind of store and forward technology, including interpretation with follow-up with the patient within 24 business hours, not originating from a related E&M service within the past 7 days, nor leading to an E&M service that would occur in the next 24 hours. So this would be the patient sending you a video, sending you images that you would then assess and then reach out to the patient to interpret that with them and go over it with them. So you have to provide that part of the service within 24 hours of receiving those images or video from the patient. And I'm making an issue of this because this isn't video that you record in a session with a patient and then analyze after you're off the phone with them and then call them back about it, right? I mean, basically, you cannot bill for an e-visit, a telephone visit, or a virtual check-in. You can only bill one code every 7 days out of all those choices. So I just don't want anyone to be confused about that. So the remote evaluation of recorded video and images may be done via telephone, AV communication, secure text messaging, encrypted email, or patient portal communication. They can't be billed if the service originates from a related service provided within the previous 7 days, and can't be billed separately if it results in a service within the next 24 hours. So this is basically the same type of limitations as the first virtual check-in code, but you want to be sure that the patient is sending you the thing that you're going to be assessing and reviewing with them. Let's move on to telephone visits. Now, the telephone visits are pretty much unchanged from the time that they were originally we were given the ability to bill for within the last 5 or 6 weeks. So the telephone visits, remember, can be done strictly on the phone. There are 5 to 10 minutes, 11 to 20 minutes, and 21 to 30 minutes. Again, they're accumulated over a 7-day period. So if you were to talk to the patient on a Monday and a Wednesday, and you reach the 30-minute mark on the Wednesday call, then that would become your billed date of service, although your documentation would reflect the services rendered on both days. Now, as with e-visits, the place of service for the telephone visits is based on the location where the therapist typically provides services. So that, again, would usually be the office, which would be place of service 11, but could be the place of service 12. Same caveats about the CR and the G modifiers. It may depend on the MAC, and it may depend where the MAC is in the process of updating their system. One of the things we found is that the MACs are struggling mightily, as are we, to adapt to the new telehealth world, and their systems are can take some time to change. So just because they processed a claim one way a week ago doesn't mean it'll get processed exactly the same way the next time you send it in. So be patient, read your admittance advice, and make whatever corrections you need to based on the denial remarks. Again, the services for the telephone visits fall outside of the Medicare plan of care requirements. Now, for a summary of changes and clarifications for all the federal payers, you can visit the shortened URL on your screen. It'll take you to a PDF that APTA maintains. You can also Google Federal Payer Telehealth Coverage APTA, and the PDF will be one of the first results. Now, they update those every Friday. Those are basically crowdsourced from the different APTA payment shares around the country. So it's actually a pretty current list, and the information is good. So now let's move away from the world of Medicare and talk about commercial payer telehealth. Now, if you thought that this area was confusing 2 weeks ago, wait till I get through with you today. The telehealth world in the commercial payer universe is like the wild, wild west. So there are significant differences from one payer to another, and unfortunately there is not a silver billing bullet I can give you that will allow you to expertly bill every commercial payer the same way. So you're going to have to look at your primary payers and understand what those are. Again, we've given you another link to the APTA coverage charts for the commercial and regional payers, and you can consult that, and those are updated every Friday. Keep in mind, though, that the rules for Blue Cross and Blue Shield differ from state to state, and there is not one Anthem Blue Cross Blue Shield policy for the large number of states that they control the Blues in. So you'll need to take the time to look those up. The nice thing is that they do a good job of being clear about what you can and can't do. So let's look at some specific national payers just to give you a feel for how things are going. So with Aetna will allow PTs to bill the e-visit codes and either the Medicare version, which are the G codes, or the CPT analog codes, which are the 989, 70 through 72 codes. Aetna notes that the providers must comply with all the Medicare requirements associated with billing the e-visits. Now, last week, Aetna said that they would cover telehealth-based delivery of services and procedures provided by PTs, OTs, and speech and language pathologists. Now, on the slide, I've only given you the PT ones, but if you go to the payment charts from APTA, you'll see all the different codes for all the different providers. The telehealth services must be provided as a two-way synchronous audiovisual service, so you cannot do these on the telephone. Providers are required to append the GT modifier to the codes. The telehealth services delivered by a therapist can be billed on a UB04 claim using the modifier GT or 95. Now, just a fine point on the difference between the GT and the 95 modifier. If you're using a true telehealth platform, feel free to use the 95 modifier unless a payer tells you that they only want the GT. The GT modifier is an older synchronous telehealth modifier that is less descriptive of the actual telehealth technology. So if you're using a real telehealth system, use the 95 modifier. Let's take a look at Cigna. So Cigna has expanded the list of covered services that PT/OT and speech and language pathologists can deliver via telehealth. And it's the idea is to include the services that you would normally only do with the patient in the office. So it's the PT and OT evaluation and reevaluations, a subset of the 97,000 intervention codes, and for the speech therapists, it's their evaluation and treatment codes. So Cigna removed their previous guidance that only a select number of codes on the fee schedule could be billed. Rehab therapists should provide and submit claims for virtual services with the GQ, the GT, or the 95 modifier, and a face-to-face service code. So that would mean place of service 11 or 12. Now, the GQ modifier is if you're only using an asynchronous platform. I've already explained the difference between the GT and the 95 modifier. So Cigna encourages therapists to follow CMS guidelines regarding virtual care software. It does not require the use of any specific software at this time. And Cigna also noted that their ancillary management partner, ASH, is applying the same virtual care guidance. So you can use the same guidance when dealing with contracts that go through ASH rather than directly to Cigna. So for United Healthcare, United Healthcare will reimburse rehab therapists for telehealth using interactive audio and visual technology. So not a telephone, but a telehealth platform. This applies to all their Medicare Advantage, Medicaid, individually, and fully insured group market products. So this is across their whole book of business. United Healthcare will not pay for telephone-only services or services delivered via asynchronous technologies. So, what that tells you is that you can't use the telephone codes, you can't use the virtual check-in codes, and you'll want to use your 97,000 series codes for United Healthcare. Cost sharing is waived, and what that means is that United Healthcare will pay the full fee, and you do not need to pick up the copay or coinsurance from your UHC patients. The place of service code is the one that would have been reported had the service been delivered in person, and you would use the 95 modifier. You'll see again that the UBO4, the institutional claims, must use the revenue code 780. And so if you're on Part A, there's another commercial payer that you can bill for your services. So on the next slide, the critical thing you want to remember here for all of these codes that are shown is that UHC will pay for one code per phone interaction, telehealth interaction with the patient. Only one of these. So I guess choose carefully. Certainly you're not limited to once every 7 days with telehealth services with United Healthcare like you would be with the e-visit codes to Medicare. But they will pay for one of these services each session. So that's a 15-minute session that they will pay for. So Humana is exactly following the CMS published guidelines related to e-visits, virtual check-ins, and telephone visits. If Medicare does waive the Social Security Act so that rehab therapists can be considered telehealth providers, then Humana will do the same thing and allow the same codes that CMS will allow us to use. So this slide here shows the CPT e-visit codes. So these are identical in definition to the Medicare G codes. we discussed earlier. I'm including them here for your convenience. All of the commercial payers that I have looked at that accept e-visit codes really want the G codes from Medicare, but you may run across a payer who wants the CPT version of those services, and you have those here, and they come with the same limitations that are part of the Medicare G e-visit services. So for a summary of changes and clarifications for commercial payers, you can visit this short URL on the slide. If you go to the APTA payer charts, you'll also find one there for workers' comp. And you'll also find the summaries of state orders, executive orders, and declarations of emergency, and that may be helpful to you if you treat Medicaid patients, and we'll have more to say about that shortly. And remember that these APTA charts are updated every Friday.
So speaking of changes to commercial health plans, the CARE Act provides a temporary safe harbor for high deductible plans, including those with a health savings account, to cover telehealth services for their beneficiaries without requiring cost sharing, regardless of whether or not the beneficiary deductible has already been met. So in other words, patients with the high deductible plans beginning before January 1, 2022, can temporarily receive telehealth services, assuming their plan chooses to adopt this program. Now, and that includes no out-of-pocket cost while still maintaining the tax benefits of their HDHP HSA.
So on workers' comp, individual workers' comp carriers have been very slow to publish anything related to changes in telehealth. Now, there are a few exceptions. MedRisk is one of those, but I can't really give you the MedRisk specifics because they're different for different contracts in different states. We've given you a short URL here, which will take you to the APTA's payer charts for workers' comp, and you can find information there. But I think the best way for you to deal with workers' comp is to call and get your services authorized, just like you would if they were going to happen in your office. And once the adjuster gives you clearance to bill for services, they'll tell you how you want them to bill them. Just be sure that you get the adjuster's name and employee ID when they give you that information, so in case there's any question, you can be clear on where it came from. So get them authorized and then go ahead and bill them. If they don't give you any billing guidance, I would definitely use the 95 modifier to show that it is a telehealth visit. Just so that you don't run afoul of maybe misrepresenting that it happened in the office when it didn't.
So many states are expanding Medicaid coverage for PT, OT, and SLP provided telehealth during this public health emergency. For example, Idaho expanded its coverage. Plans of care are not required, and participants may receive telehealth in any place of service. In other words, the originating site may now be the home. New Jersey now authorizes telehealth and recognizes out-of-state licenses that are in good standing. Wisconsin allows telehealth for services that can be provided via interactive live video. In other words, not for any service that requires physical interaction, hands-on support, or physical prompting. And Nebraska now reimburses for telephone encounters. Many states are temporarily authorizing therapy services delivered via telehealth, reducing delivery requirements, and even mandating insurance coverage. For example, Arizona insurers are mandated to cover health services provided via telehealth that are covered in person. Colorado expanded its coverage and authorization for telehealth so that services are not restricted to video. Audio is now also permitted. Massachusetts expanded its list of all telehealth providers and also allows for audio delivery. Maryland expanded its telehealth provisions to include the home as the originating site and alleviate the requirement for explicit patient consent unless the audio and video do not satisfy state requirements. And Ohio lifted prior telehealth restrictions such as no initial face-to-face encounters required and audio-only services are reimbursable. However, it's very important to note that once the crisis is over, providers will have to obtain authorization from state legislatures to continue to be able to provide these services. So all of these insurance expansions were made under an executive order during the crisis, and those will go away when the crisis is over.
Now, we've also seen some payers relax limitations on providers' abilities to deliver telehealth services across state lines. And although it's worth noting that this is also a state-level issue, while some states were already part of the PT state licensure compact, others have taken action to remove this barrier in light of the crisis response. And before that, we go on to our next point, we do have some breaking news courtesy of Rick Gowenda of Gowenda Seminars. As of April 16th, 2020 at 9:40 a.m. Pacific Time, CMS has added CPT codes used by PTs, OTs, and SLPs as covered telehealth services. But, and this is a big BUT, they have still not added PTs, OTs, and SLPs as telehealth providers. So while we're moving in the right direction, advocacy is still needed to just get us across that finish line to add us as rehab therapists, as telehealth providers. So thank you, Rick Gowenda, for that via social media. So bringing to our next point of what happens beyond this crisis and whether or not, we actually retain our telehealth privileges after this crisis ends is unknown. But there are things that we can do now in the midst of this to help nudge things in our favor. For starters, that means we must show the value of rehab therapy telehealth services. So let's talk about some best practices for accomplishing this.
So first, create a uniform process to prepare for all telehealth visits. This means setting up your location with the tools and resources that you'll need to conduct the session. And then educate your patients on the benefits of these types of telehealth services, as well as show them how to use the technology. Send your patients emails in advance with agendas or lesson plans that help them also prepare for the session and keep structure. Maintain professional conduct throughout, including only conducting sessions in a private location, ensuring that you won't be interrupted, and testing all technology in advance. Create intervention plans based on evidence and the literature, and be creative and flexible. Next, make it a point to collect data to add to the evidence base for telehealth services and share that data with your professional organization. I know that the Arizona OT Association is inviting OTs to submit data on telehealth, and I imagine that other state associations as well as the national associations would be similarly interested.
So finally, recruit patients to advocate for greater access to rehab therapy telehealth, as they really must hold and really sway lawmakers at this point. And in order to do this, we want to consistently educate patients on the benefits of telehealth, explain that telehealth is part of the plethora of service offerings and can accompany face-to-face visits, educate patients on when telehealth is appropriate, such as for education and providing instruction when the patient is in the home. And finally, obtain informed consent by explaining the pros and cons of telehealth, including the privacy and security risk, and educating the patient on how to prepare for the patient to get the most out of this visit. Now, the informed consent can come in the way of a signed form, which I recommend, or it can come in the form of verbal, but should be documented regardless of method of acquiring that informed consent. Make sure that we are documenting that in your note for these particular visits.
All right, we did it. Whew. That was a big presentation. Okay, we're going to go ahead and launch into the Q&A, and we're going to tackle as many questions as possible. But again, just a reminder to everybody, we will email this presentation to all of you. Everybody who registered for this will get a copy of the recording and the slide deck, as well as a very hefty FAQ covering every question that has been lobbed our way over these past several weeks during the pandemic. So if we don't get to your question today, please check that FAQ. It covers a lot. And then, as always, you can reach out to us through all our different social media channels. What we're going to do today is tackle the most commonly asked questions. So if your question's very specific, please keep in mind that it might get answered through another question that's a bit more broad. With that, I'll lob it over to Heidi.
Thank you, Shar. So the majority of our questions coming in, I think, are mainly geared towards telehealth. So, John, I'm going to direct those questions to you specifically out of the gate here. Let's start with specifically, we just ended on talking about workman's comp. So you had mentioned some ways to make sure that can workman's comp cover telehealth? So can you just review those again?
Sure. I mean, I think with any workers' comp service, you should get it authorized before you deliver it. And that's true whether it's in your office or whether it's delivered via telehealth. That way you'll at least know going in whether or not it's going to be approved by the adjuster. Even though the payer may not have its own published policy, the workers' comp adjusters have a lot of leeway relative to the workers' comp contracts to approve services. So I think that's really your best bet. I would submit those claims with the 95 modifier on them so that there's no confusion about whether these were delivered in the office or whether they were delivered via telehealth. Again, using place of service 11, which is your office.
Place of service 11, and then I would also specifically, when you think about the limit on numbers of telehealth visits, you're going to want to specify how those telehealth visits are going to adjunct your current care. Obviously, today we can't, or if your clinic is open, and if your clinic is not specifically open, how would you then ask for 100% telehealth visits? And does this also apply to no fault? I would assume the same sort of categories would apply to no fault.
I would assume so. I mean, none of those payers are publishing anything, so I think you're best off calling them and then just being clear in your medical records what you're doing.
And John, we've talked a lot about the codes to be used. Has anyone actually received payment from Medicare for these codes?
We've seen payments from Medicare from, I would say, about 2/3 of the max. The other third we haven't heard anything from. And in fact, we got a bunch of denials from Noridian last week because they hadn't made the changes in their system yet. But, so if you're billing and getting rejections or denials, try to take action based on the information they give you in their remittance advice. If you're not hearing anything, I think you just need to wait for them to get their systems processing correctly so that they can deal with your claims.
I would agree, and I just actually got a text from a friend who's watching this webinar right now and had mentioned that they are in Oregon and have gotten paid for services through Noridian. So I agree, John. It's patience right now. Everybody's transitioning to new codes and trying to get their things in order. So speaking of that, we have a question, kind of a specific one, but I think it's along these lines of being denied with reason code C016, which means that their claim service is lacking information needed for adjudication. So they've included modifiers GP and CR and 95. So do you think they should just be patient, resubmit?
I don't remember hearing whether this was Medicare or commercial. I mean, I would certainly call and see if you can get any information from the person talking to you about your claim to see what can be changed to get it payable.
Yeah, it was a Medicare e-visit code.
Okay. And well, it would depend on the MAC too. But again, I would. The problem is probably going to be either the CR modifier or the GP or GO modifier. And you might want to call and ask that specific question because that might help them answer you better.
John, do you know if any payers are still accepting new providers into their networks during this time? Are networks still open for business?
Well, that's another thing that's all over the place. A lot of payers are doing temporary or accelerated credentialing in order to get patients access to services. So you should call on any payers that you're interested in trying to get on with that you're not on with, because it's highly likely that if you can get in under this accelerated process that you'll be able to stay in after it's over. I doubt that they're going to kick you out.
Okay, we've talked about this many times throughout a couple of our different webinars, but I'm going to throw it out there for emphasis again. Can rehab therapists bill telephone visits as time services, or should they be billing them as time services, direct or indirect minute times? And do they count towards your visit count?
Yeah, well, okay, it should not count against your plan of care. That's for sure. I am not in the WebPT EMR every day, and I haven't been in it in the last week. So the way you should think about those codes is they're timed, right? Because they tell you the minute envelope that you have to work with to deliver that service. And I would say that it's all direct minutes, right? Because you're on the phone with the patient for all of those minutes. So that's how I would handle that.
And we can provide, our member services team can also help with more specific WebPT questions about how to properly document and code or utilize those codes. John, last sort of specific billing question. Can we provide an e-visit and a telephone visit to the same patient during the same 7-day period?
You cannot. You can only bill one of those services every 7 days, whether it's a e-visit, a virtual check-in, or a telephone visit. You're limited to one visit every 7 days.
Okay, and I had alluded to during the presentation about the question, can PTs bill incident to a physician in order to provide telehealth services to Medicare patients? And originally, based on Medicare, they did say that PTs could do that and get paid. However, on a call yesterday with CMS, the specific question was asked to CMS by Rick Wenda, and the answer was no, that would not be allowed, that PTs and OTs doing telehealth and billing incident to a physician, if employed by a physician's practice, could not actually bill and get paid for Medicare services. So there's a conflicting information out there. So again, as John has mentioned many, many times during this presentation, please reach out to your respective MACs and continue to watch the CMS website for immediate updates because things are changing very rapidly. So let's transition into some questions. Vita, can we ensure HIPAA compliance while therapists are working from home, or how do we actually ensure HIPAA compliance?
So remember that OCR, the Office for Civil Rights, is tightening up its enforcement. It's not tightening it up. It's actually not going to be as strict about enforcing HIPAA compliance for the video platforms such as Zoom and DoxyMe during this period, but providers still have an obligation to implement those security and privacy requirements outside of the video platforms. That means working in a private place. A lot of providers may be in their home, so working in a private room where other family members can't see or overhear patient information. Getting those policies and procedures in place. This is a good time to do HIPAA training, especially around the telehealth, to make sure that the employees know that they still have to protect that patient information And while we can't control the patient, we could send them information about how to protect their own information, keeping their own sessions confidential if they're interested in that when they're getting those services in their home.
Great. And a lot of questions around the PPP loan. So we temporarily laid off employees while waiting for the PPP loan. Now that we've received the funding, do we just rehire those employees, or is there another process that we must follow?
So yes, you can rehire those employees. I was reviewing the SBA's interim final rule, and they do indicate that if your employees have collected unemployment during that time period when they were laid off, that may affect your unemployment insurance at a later date. They are going to release more guidance about that, but right now there's not details about that. But you would just rehire those employees, and then you can use your loan to cover those payroll costs, and then those costs would be forgiven because you're using them for payroll.
And if we've received our PPP funding, can we still ask employees to use their PTO time?
Well, the PPP funding does include PTO time, so you can do that. That would be covered under the forgiven amount. And just remember that you can use your loan funds under PPP for anything. It's just that anything that's not payroll or utilities or rent will not be forgiven. It will be transferred into a loan that you'll pay back.
Right. And along those same lines, if you have received a PPP loan, there's sort of a question that was interesting, that they've gotten their loan, but some of their therapists actually that are currently employed don't want to work because of the fear of contracting the virus. And so the question was, should we hire additional therapists so our payroll numbers come closer to that 75% of the loaned amount?
And I would say yes. I'm sure there's a lot of therapists that will be very happy to come in and work.
There's been a lot of controversy, Vita. Social media has been filled with issues around people not being able to use their current maybe local bank to ensure that they are able to get in this loan request. Now, obviously, our breaking news states that these loans have been currently stopped because there is no more funding. But in the future, how do I go about, if this opens up again, how do I go about choosing the right bank to enable me to get these loans?
So go on the SBA website, and there is a feature that can help you locate lenders in your area. You just type in your zip code, and that's the best bet. Go right to the source.
That's right. Always go straight to the source. And if you have already applied and you've been approved, if you're in the application process, I do not think because they have closed all new applications that means you will not be getting funding. It just means that they know based on all of the applications that there is no more money to go around. And so I would not assume with your application in that means that you will not get funded. Most likely you probably will, but just stay in contact with your lender, your bank, to find out exactly what's going on in the process and where it is in the process. Vita, one last question with regard to clinic, and maybe I can answer this one as well, but just with regard to recommendations, if we are going to, as we start to move into opening more clinics back up, getting businesses back and going, what are some recommendations for PPE to have in your clinic?
I think this is a good time to recognize that you need to develop a continuity plan, stock up if you can. Some states are even offering to ship out PPE, so look on your Department of Health website, and possibly even making your own. CDC guidelines say that anything will be sufficient, even if it's a bandana. And then just continue that hand washing.
Yeah, I would agree. Getting very specific policies in place for not only your employees, and I would recommend wearing masks, wearing gloves at this time, having hand washing, obviously before and after every patient that's visible to the patients, even potentially having your employees wear scrubs or clothing that they wear specifically during that day that they then take off before they go home, so that you're limiting the spread as much as you possibly can for any potential vectors that either they or patients that come in. And then having also very specific guidelines for your patients in terms of policies, including temperature checks when they walk in the door, that they have to be wearing masks as they come into your clinic. And, obviously anyone who is showing any symptoms needs to not come to their visit and cancel. And same thing with your employees. If anybody's showing any symptoms, they should not be coming to work that day. So this is the time to be rewriting a lot of policies. They may be temporary, but I think these are probably going to extend most likely into Q4 in terms of people continuing to have these fears as we watch how things evolve, whether we see it upward spike again, which is most likely based on most of the researchers out there saying there will be another spike once businesses start to open. So we are essential. We should be out there treating patients. But obviously you want to have the appropriate PPE and protection available for not only your employees, but your patients as well. And then one other question just on business continuity: how can we actually expand and cultivate referral relationships when face-to-face meetings aren't possible? And I'll let all three of us answer this because I think it's unique, maybe Vita, especially with your OT background. But for sure, I mean, everybody's in downtime right now, right? So figuring out ways to, if you have personal relationships with physicians who are your referral sources, call them on a personal level, send them an email, just checking in on their families and how they're doing. I meing, these personal relationships can be built even stronger during this time. The thing that people want to do this time right now is go insular and just protect everyone close to them. But this is also a time to be reaching out to the community, reaching out to your referral sources specifically, see how they're doing, but also try to educate them on what you're doing. Share stories at how your continuity plans and what you're planning to do as you open up. Many of the questions that we're having today, I'm sure that physician's office, and I know the AMA is also discussing with their constituents. So sharing that information, we're all kind of in this same boat as healthcare providers, can be super helpful and develop relationships even stronger moving forward for sustainability of your clinic.
And then I'll just jump in and say that read the book, Never Eat Lunch Alone, and use this time to develop those networking skills, because developing your referral base is more than just bringing donuts to the physician's office. So, learning yourself how to cultivate those really strong, deep relationships.
A lot of you treat people from big employers, and these people are now working at home. So you can have a really great marketing outreach by offering 5-minute, 10-minute home office ergonomic consultation, and use that as a marketing technique. And being sure that your referring physicians know that you're offering that to them and their employees too.
Great. That's great, John. Thank you for that. And we still have a lot of people hanging on. We have more questions, so we're going to keep going. So thank you all for sticking around. Vita, a few more questions regarding PPP. Can you explain how the Paycheck Protection Plan interacts with the EIDL?
So the EIDL is an emergency loan, and if you are advanced money during this time, you can use it for anything, and that first $10,000 you don't have to repay. Now, if you decide to apply for the PPP loan and you were using those EIDL funds to cover payroll and mortgage costs, then this is a good time to refinance that money into a PPP loan.
Okay, and can you use the PPP funding to provide back pay for employees who have not been able to work?
I would say yes, you can. Please keep in mind we're not the experts on this, and I would even say the SBA isn't the experts. They're still coming out with the final rules, so stay tuned. But the PPP loans are to pay to keep your employees retained. So if you're using that for employee compensation, as long as it's under that $100,000 a year, then you should be good to go for the forgiveness portion. And I'll just remind everybody, this is a loan. So if you use it for other things, you'll just have to pay it back. So it's not that you cannot use the money for non-payroll costs.
Okay, last question on the business side before we have just a few more questions on the virtual visits. Vita, can you explain a little bit more about the tax-free employer student loan contributions, and how is that a benefit to the employer?
So this is an existing program that employers could compensate, or the employer could pay the employee's student loans, and this is to attract those hard to find talent such as PTs, OTs, and speech therapists. So the program was in place, but now the employee can also, I think that what I may have to do, there's a lot of details around the tax deductions and the fact that if the employer pays, it won't be taxable income for the employee. And so we probably are best to handle that in the FAQ just to make sure that we're getting those details right.
Thank you, Vita. John, a couple more questions coming in with regard to some of the finer details in the definitions of all of our virtual visit opportunities. So if you have a phone discussion with a patient and then follow up with an adjusted home exercise program interchange via email, how would you actually bill for that?
You would be stretching the limits of all the definitions if you tried to do that with Medicare, because Medicare says that has to be delivered via a patient portal. The other problem that you have is you can't bill for an e-visit for the first half of that and then bill for a virtual check-in for the second half within 7 days of each other. So I really think that you would be better not answering by email. And if you have minutes left from your e-visit from your initial call, I would do another call and add those minutes to it so you can get the full 21 minutes.
We'll go ahead and wrap up. Heidi, are there any other questions that you or I can tackle?
Yeah, so how can WebPT help with remote or these virtual treatments?
Oh, it's like you just served that up perfectly for me. Yes, WebPT can help with virtual services. So first, as we've stated in previous webinars, the WebPT HEP, you can use that to facilitate e-visits. The way you would do that is the patient is going to initiate the communication via the secure messaging function within the HEP. And upon doing that, you can then interact with the patient using the HEP and then document and bill for those e-visits. Now, the other way that WebPT can help with virtual services is through a brand new development we're very excited to share, that this week we are rolling out a new virtual visits feature. We have live two-way video that you can launch out of the WebPT EMR so that you may conduct virtual therapy services. So the True Blue Telehealth that we've been talking about, that live two-way video, HIPAA secure, we now have that available within the WebPT EMR. So we're rolling that out to members this week. And starting next week, we'll begin opening it up to new members. People who are switching to our EMR may also take advantage of this virtual visit feature. So that's very exciting news. We worked our tails off to get this developed really quickly. So please watch your inbox next week. We will be emailing everybody who has registered for this webinar additional details about both our HEP, which can facilitate e-visits, and the WebPT EMR, which enables you to do the live two-way video. So with that, Heidi, is there anything else we want to cover?
I just want to remind all those WebPT users out there that for documentation of these types of virtual visits, document clearly as to getting the consent to do these virtual visits from your patient, whether that's a signed form that you can send them, whether it's an email consent or a verbal consent, just document that appropriately. And then also make sure that you know that within WebPT we have all of the visits available. Whether that's whether it's e-visits, telephone visits, or elsewhere. So all of those are available in WebPT. So thank you. And
thanks, everybody, for joining us. Have a good one.